vitals, and on physical examination, he's having stable vitals, and on physical examination, there is no other abnormality, and he's currently being posted for cleft palate repair surgery.
Okay. So very often in our setup, we come across no plastic surgery list is complete without having a cleft palate or a cleft lip repair. So what do you think is the incidence in the Indian population or the Asian population of cleft lip and palate?
It has been seen that in India, the incidence of cleft lip with palate is around 1.09 per 1,000 live births. And in Asian population, it ranges from this 1.09 to around 1.7 cases per 1,000 live births, roughly around 1 in every 600 to 700 live births.
That's approximately as close globally, but there are certain population like the Africans who would be having a very low incidence, while the others like the Asians who have a relatively higher incidence.
Yes, ma'am.
You said that this is a cleft lip grade 3. Okay.
Yes,
so how do you classify this cleft lip and palate?
in our institute, we usually use the Indian classification system, also known as Nagpur classification system for classification, which was developed by Dr. C. Balakrishnan. According to this classification, the cleft lip and palate have been divided into 3 grades. In grade 1, there is only cleft lip, and grade 1 also has a subtype, grade 1A, in which there is, along with cleft lip, there is a defect in the premaxilla that is anterior to the incisive foramen. In grade 2, there is only cleft palate, and grade 3, there is combination of cleft lip and cleft palate. So the child is under category of grade 3. He is having complete cleft lip as well as cleft palate.
So he is having cleft lip, left-sided cleft lip and palate. So what is the most common presentation we come across of this clefting disease?
In Asian populations, the most common presentation is of left-sided complete cleft palate.
Cleft lip and palate or cleft palate?
Cleft palate alone, ma'am.
Okay. So the incidence is more common in male, female. Do we have any gender predisposition or preponderance?
In this case, it is more common in males, around 2 times more cases in males as compared to females.
Here I would like to correct you, Himanshu, because cleft lip and palate together, the incidence is definitely more in males. But if we talk of isolated cleft palate, then the incidence is more in females.
Females, yes.
Right?
Yes.
So let's come to your slides. Let's go back to your history, how you started off. Can we have the first slide?
Yes, ma'am. I have to stop it.
How do you go back?
So I'm going back.
Yeah. It's not going?
I'll have to share my screen again, ma'am. I'll do it.
So in the meantime, when you're doing it, so your case had a presentation that this child came to the hospital for the repair of cleft palate, right?
Yes, ma'am.
So what are the potential problems which can arise because of this cleft palate defect?
Because of this cleft palate defect, first, there would be difficulty in feeding. The child won't be able to generate.
I asked cleft palate. You can say cleft lip and palate. Because of lip deformity, there would be more problem with the feeding thing. With cleft palate, you have other problems. So you should be able to differentiate what problems are because of cleft lip, what problems arise mainly because of cleft palate. Right?
Because of the defect in cleft palate, there would be more chances of nasal regurgitation of feed. While if there is cleft lip, then the problem would be difficulty in feeding, mainly difficulty in suckling, as the child won't be able to generate negative pressure for suckling of milk.
Right.
And because he won't be able to take feed properly, there would be nutritional problems in the child.
Okay.
And also the pharyngeal musculature won't be developed properly. It won't be functioning properly because of this defect of cleft lip and palate. So the eustachian tube is also abnormal in these cases. So there would be high chances of recurrent ear infections.
Nice.
And because of this recurrent regurgitation also there, that also leads to recurrent respiratory tract infection in these cases.
Yes. So, okay. Can we go to the next slide?
Yes.
Yeah, the next one. So that's why I think you've taken this history of difficulty in suckling, nasal regurgitation, and your patient had a history of difficulty in feeding, nasal regurgitation of foods, and difficulty in vocalization because of this defect.
Yes,
Right.
ma'am. Yes,
So
ma'am.
this child also has a history of being operated for cleft lip repair 7 months. So roughly that would be when he was 4 months old, right?
Yes, ma'am. Yes, ma'am.
So when you give anesthesia to a 4-month child and you know that the child is having another defect, cleft palate also, why didn't you get the cleft, why can't we get just this cleft lip and repair done together at the same time? Okay, giving anesthesia exposure to a child twice.
Yes, ma'am. It has been seen that these two operations, first is the repair of cleft lip and the repair of cleft palate, they need to be separated for some duration. First of all, first we do a cleft lip repair at around 3 to 6 months of age. The cleft lip repair is a bit simple procedure compared to a cleft palate procedure. And it has been seen that earlier repair first gives a good cosmetic result. Along with it, if it is corrected, then the child would be able to take in feed properly. And then if the child is able to take the feed properly, it gives us a window for nutritional buildup of the patient. So once we have corrected the cleft lip, we will provide nutrition to the child. He will gradually build up his nutrition, and at the age of around 9 to 18 months, he would be a bit more ready to undergo a cleft lip repair, which is a bit more complicated surgery. And it has been seen that uh, if the cleft palate repair is done earlier than 9 months, then there can be scarring of the growth plate that might restrict the further development of the palate. Uh, so I think this is the reason why these two surgeries, cleft lip repair and cleft palate repair, should have a gap in between.
I think, yes, you're right. Other than just building up the nutrition, because these child can have other congenital anomalies, as you've said in your presentation also. So
Yes.
you will get time to actually get them evaluated, optimize, and prepare them for a relatively major surgery.
Yes, ma'am.
So why did you take this history of excess cyanosis, excessive sweating, and abnormal body movements?
Ma'am,
What is the
cleft lip
significance
and
of this?
palate, these are also associated with congenital cardiac anomalies. So mainly to rule out any congenital cardiac defect, I took the history of cyanosis, excessive sweating during feeding, and recurrent chest infections.
Which congenital cardiac anomaly would you come across more frequently in this?
Most frequently, ASD's incidence is maximum with these cleft lip and palate. And after ASD, there can be VSD and coarctation of aorta. So these are very
Maybe,
common in these patients.
yeah, acyanotic, and then but you can also have cyanotic, like,
Yes.
yes, good.
Yes.
So currently your child is fortunately not having any cough, fever, or ear infection. Move on to the next one.
Okay.
So in the birth history, so if another thing, you said that your patient in the previous time, you said that your cleft lip surgery was done at 3 months, and now the child is coming after at 11 months for
11.
cleft palate repair. Have you heard of Kilner's rule of 10, which also tells us
Yes, ma'am.
when to do these surgeries?
Uh, earlier, earlier a rule of 10 earlier followed. Kilner's rule of 10 was followed, which gave us idea whether the child is fit for surgery or not. So according to that rule, a child is considered to be fit for cleft lip repair if his age is more than 10 weeks, if his hemoglobin is more than 10 gram per deciliter, if his TLC count is less than 10,000 per mm cube, or if his weight is more than 10 lakhs. And for cleft palate repair, if his weight is more than 10 kg, and if his age is more than 10 months, and the rest criteria being the same, then he is considered fit to undergo a cleft palate repair.
Okay. Your patient, you said that they would be having difficulty in feeding also, but luckily your patient did not show any history of being malnourished. There's no history of being malnourished. So
Yes.
how was this child fed?
I'm the parents of the child are well educated and they were very much careful about the feeding of their child. So they and in this patient, breastfeeding is a bit difficult. So they mainly gave spoon feeding to the child at very frequent intervals, and also in between they gave burping to the child. So mainly they use the technique of spoon feeding for building up nutrition in their child.
So any other precautions which we need to take when you are feeding a cleft palate child, cleft lip, or a palate child?
We need to keep the child in upright position. And breastfeeding is a bit difficult in these cases. So apart from so we have other methods to provide feed to these patients. Like we have Mead Johnson cleft palate nurser bottles, and we can also use palatal obturators in these cases. And there is also a method of palate eye. It is a spoon-shaped instrument that is used to provide nutrition to the children.
You talked about specific bottles. What is so special about them that
yes, we have a Haberman bottle and the Mead Johnson feeder bottle. In these bottles, the nipple is elongated so that it covers the palatal defect. And at the end, there is a Y-shaped nipple which gives the child milk in a bit less negative pressure. The rate of flow would be slow.
Needed, so they can be fed easily, right?
Yes.
So they were fortunate. We don't have too much blood loss and too much of a weight loss in this child.
Yes.
So coming on to the birth history. So this birth history is very important to take very precisely, because that can point out towards the etiology of cleft palate. What are the basically reasons why these patients have cleft lip and palate? What is the etiology behind that?
And the main etiology is during the development of this lip and palate. If you see, there are certain genetic factors and environmental factors that are there, which cause these defects. If you see during development, then first is that during the there is a fusion of the medial and the medial nasal process as well as the maxillary process with each other for the lip development.
For the embryology, just tell me what are the factors which can predispose or which lead to cleft lip and palate?
So there are certain environmental factors in this. First is the advanced maternal age. Advanced maternal age is a risk factor for development of this. If there is maternal smoking, maternal alcohol consumption, then certain drugs which are teratogenic, like anti-epileptic agents like phenytoin, and antihypertensive agents like ACE inhibitors or angiotensin receptor blockers. Then we have isotretinoin, steroids. And also antiviral agents are also there, like lamivudine, efavirenz.
And maternal infections as well.
Maternal infections, yes.
Right. So these infections, so at which particular stage do you think that when the female catches this infection or takes these drugs can predispose to cleft palate? If I point out to a specific duration.
In the first trimester, the development of lip and palate takes place around 4 to 10 weeks. So if the female gets this infection around 6 to 10 weeks of gestational age, then there are more chances of development of these defects.
Right. So here you took the history of no other congenital anomaly.
Yes.
So what congenital anomalies were you anticipating in this kind of a child? What are the associated congenital anomalies which you come across?
So these defects, cleft lip and palate, are associated with many other syndromes which may have other congenital anomalies. Mainly, I was looking for any cardiac anomaly or anomaly in the genitourinary system or any central nervous system anomaly. Or
you have different syndromes also. You have various syndromes. More than 300 syndromes are associated with cleft lip and palate.
Yes, ma'am.
Can you enumerate a few of them which are important for us as an aesthetist?
Okay. So most commonly it is associated with van der Waals syndrome. Apart from this, the syndromes that mainly concern us are Peary-Robin sequence, Treacher-Collins syndrome, Golden Heart syndrome, and velocardiofacial syndrome, also known as DiGeorge syndrome. So these, and also Down syndrome. So these syndromes are of main importance for us because they make the airway much more difficult.
Right. So you are not going to ask these fancy names to the mother and say ki whether your child is having a history of Perry Nobbins or your child is having Treacher. She would be knowing these names. So
Yes,
how do you take this? How do you elicit that this problem in a child?
mainly, I would examine my child to look after these problems.
So
Like
it's just the history and examination which is going to point out.
yes,
Right. Move
yes,
further.
like in PD Robbins sequence, there is micrognathia, glossoptosis along with cleft palate. And with increasing age, the intubation becomes easier. The airway becomes easier in this patient because of the maxillary growth.
Okay,
Sorry,
we'll talk
mandibular
about
growth.
that in the examination. Move forward.
Okay.
History of, yeah. So the past history, I think history of surgical repair, you have already told us why. This history seems very important for you. For us, no?
Yes,
History of surgical repair of cleft lip done at 4 months, and there was no history of perioperative complications.
yes,
Okay, it gives us a sigh of relief that the child has underwent of one surgery before without landing up in any complications. Right? Oh,
yes, ma'am.
so
Uh, mainly our concerns in these cases is of our airway. So if there was no perioperative complications, that means that the airway was secured in this patient.
yeah.
We don't need to worry much.
So other than this, what else history you've taken? Past history and
History of blood transfusion, drug allergy, and
next slide.
immunization.
This is the development history. Yes, the child would. You also said there's history of some difficulty in vocalization.
Yes, ma'am.
But here the language hearing seems to be normal in this child.
Yes, ma'am.
Because it's difficult for at times the parents to gauge the difficulty at such a young age because the child is just blabbing. So there can be a delay there.
Yes.
Right.
Yes.
Next on the history of family history. Again, this is very relevant in our case. Why?
It has been seen that if both the parents have the defect, then the chance of a child having been born with a cleft lip of palate is around 10%. And if only one parent is affected, then the chance is around 3%.
Okay.
So in my case, none of the parent was having this defect.
Basically, to find out the reason for cleft lip palate, you need to rule out the genetic, the familial, the environmental factors, the genetic factors, the familial association. Along with that, there can be another cause for cleft palate there is another cause for cleft palate, which can.
There can be obstruction coming in between when the palatal shelves are growing. Like if the child is having very large.
Mechanical cause also. That mechanical cause. And this obstruction comes
from the tongue, ma'am, with a large tongue.
So if they have a large tongue, then this can come in between and the palate will not unite. As the result, it can lead to a cleft palate. Yes. So that's all about the history. If we proceed to the examination, Dr. Komal, would you like to add anything?
Yeah, so Himanshu, you very well said that there are multiple mechanisms which leads to the development of cleft lip and palate. So for the sake of the house, I would like you to tell us embryologically how the cleft lip and palate happens in a newborn or in a neonate.
So can I show it with a diagram?
Yeah, sure.
So show it with the diagram. So as we can see, the development of cleft lip and palate, it starts, the development of lip and palate, it starts at around 4 weeks of the gestation life and it ends by 10th week. So at around 5 weeks, there is development of frontonasal process, 2 maxillary processes and 1 mandibular process. Then at around 6 weeks, this frontonasal process gives rise to a medial nasal process and a lateral nasal process. Then there is growth of this medial nasal process as well as the lateral nasal process. The medial nasal processes fuse to form the philtrum of the nose and the upper part and the center part of the upper lip. And also the lateral part of the and the lateral nasal process, it forms the ala of the nose. Then there is fusion of the medial nasal process with the maxillary process that leads to the formation of upper lip. If there is any defect here, if there is a failure of fusion of medial nasal process with the maxillary process, that leads to development of cleft lip. So this fusion completes by around 7 weeks. And for the development of palate, the maxillary process, the palate is developed. Mainly, there are two types of palate. One is the primary palate, and other is the secondary palate. The primary palate's development takes place by the elongation of the frontonasal process. Anterior to the incisive foramen, we say that there is a primary palate. So its development takes place by the frontonasal process. While for the development of the secondary palate, which includes the hard palate and the soft palate, there is outgrowth known as palatine shelves that outgrow from the maxillary process. Both of these palatine shells then come near each other, fuse in the midline from the anterior towards posteriorly, and this fusion gets completed by around age of 10 weeks. So if there is any defect in the fusion of these two processes, that leads to development of the cleft palate.
Oh, so very correctly you explained. So your patient was diagnosed having an anomaly of the cleft lip along with the cleft palate postnatally. So how early one can detect the presence of cleft lip and palate in a newborn or in a child or even before that?
In antenatal ultrasound, it has been seen that around 18 weeks of gestational lives, we can detect the cleft lip. But for detection of cleft palate, as the palate is inside the oral cavity, it is difficult to see the cleft palate directly by antenatal ultrasound. But if the child is having other associated anomalies like micrognathia or mid-face hypoplasia, or if he's having polyhydramnios, then that suggests to us that cleft palate might also be present in that patient.
Mother would be having polyhydramnios, not the child. The
The
child.
mother will be having polyhydramnios. So you need to be suspicious about presence of congenital anomalies which can give rise to the polyhydramnios. So as we have already discussed, there are many syndromes which are associated with the presence of cleft lip and palate. You very well said about Robin sequence. There is one more syndrome called Treacher-Collins syndrome. So can you tell me what particular features you will see in a child while examining or taking the history for this syndrome?
Treacher-Collins syndrome, along with this orofacial cleft, we have micrognathia, along with mid-facial hypoplasia, a flat nasal bridge with ear anomalies and eye anomalies. And in these patients with increasing age, the intubation becomes much more difficult.
Why so?
Because already there is mid-face hypoplasia, and with increasing age, that the development of that maxilla or the palate, it makes with development, it makes the airway more difficult because it develops in that certain way, making the airway more difficult.
So one more thing we discussed that the child underwent repair of the cleft lip at the age of 4 months, right? But then there were no peri-operative complications. So what perioperative complications you anticipate in these children? Like presence of one is perioperative respiratory adverse event, right?
Yes.
So because you said that these children are very prone to have the recurrent upper respiratory tract infection. So suppose like this patient, the current index case, if the child is noted to have the active cough with cold a day prior to the surgery when you went for the pre-anesthetic checkup. So will you proceed with the surgery still?
I would first examine the child. I would see if the child is having productive cough, if the nasal secretions are purulent, if he's having fever more than 30 degrees Celsius, if there is leukocytosis, and on auscultation, if he's having wheeze or crepitations, then I would like to delay the surgery. Because it is an elective procedure, and if the child is taken in such a condition, then there is very high risk of any major perioperative respiratory adverse event in these children.
Okay, so you uttered few investigations, so leukocytosis and all that. So can you tell me what all investigations you want as a part of pre-anesthetic checkup in a patient who is planned to undergo elective surgery for cleft palate or cleft lip?
And particularly in my patient, he is undergoing cleft palate repair. So in cleft palate repair, it is a bit more extensive surgery. So in this case, I would order for a complete blood count, including hemoglobin, total leukocyte count, platelet count. I would ask for a renal function test, serum electrolytes, and a coaglogram. And it would be better if the child already has undergone some congenital anomaly scan like 2D echocardiography to rule out any congenital cardiac anomaly.
Okay, so you actually demand for 2D echo in each and every case of cleft palate, or what is your institutional protocol?
In our institute, it is a protocol to screen any child for any other congenital anomaly. So yes, in all the cases presenting with some congenital defect, screening 2D echocardiography is done in every patient.
But then can your history or your examination points towards the need for 2D echo? So what are those clues you may get from your history taking and the examination part?
So I took history of any episode of cyanosis or excessive sweating during feeding or recurrent upper respiratory tract infection in my child. So that history I took to rule out any cardiac anomaly. And on examination, if there is an audible murmur, then there can be a problem with, there can be congenital cardiac anomaly in the child.
So this is about cleft palate. What about if patient is planned for a elective cleft lip repair?
If the patient is planned only for cleft lip repair, then I would ask for only complete blood count. I would like to see hemoglobin and total leukocyte count.
Okay, so from your investigation, now we move on towards the anesthetic management. So
Yeah.
I think Dr. Divya can start the discussion.
Before I start that, you said for cleft lip, I'll go for, this is a very small child, and the cleft lip surgery, you were saying, you've been consistently saying, it's a very minimal, non-invasive type of a surgery. So still you would like to go in with the proceed with getting a complete blood count. What is the significance of having a hemogram in such a small child for a surgery which you know is not going to bleed that, it's not going to bleed that much?
It has been seen that if the hemoglobin of the child is more than 10 gram per deciliter, then wound healing has been seen to be much better.
So, but do you expect hemoglobin of less than 10?
Mainly these children are not able to feed properly. There is some nutritional deficiency in these patients. So
along with physiological anemia, you can have nutritional anemia also. So it's better to always go in with CBC.
yes.
Yes, so nicely done. Now you have done your history examination. So we proceed towards anesthesia protocol. Okay, right. So what are your main anesthetic concerns for a patient who's going to come for an 11-month child who's going to come for a cleft palate repair?
My main concerns for a child under 11-month-old child undergoing cleft palate repair are, first is the airway. A patient with cleft lip or palate is always considered to be a difficult airway. Second, these patients are of pediatric age group. So all the concerns of a pediatric age group would be applicable in these patients. Then they have associated other congenital anomalies as well. So I also have to take into account this factor also. And also they have a history of repeated recurrent upper respiratory tract infection. So any perioperative respiratory adverse event can also be there. And after the end of surgery, there is a high risk of post-operative airway obstruction in these patients. So these are my major concerns for this surgery.
There is another concern which is very important, is that these surgeries are a shared airway surgeries, right? So
yes.
Along with the airway concerns, you said this is going to be a difficult airway case.
Yes.
So where exactly do you think, my field of interest is airway management. So I have precisely asked you, where in airway do you think you are going to have difficulty? Is it
Um,
ventilation, laryngoscopy, intubation? Where in this particular patient?
in my patient, he is having an isolated cleft palate, so I will be having a difficulty in laryngoscopy more. My laryngoscope blade might actually hinge on to the cleft palate defect.
What about mask? So you think you're not going to have major problem with your mask, face mask ventilation?
There is no cleft lip. Cleft lip is not there. So and also last time he was operated.
It has been operated. So majorly you're not anticipating any leaks out there,
Yes,
right? And what about intubation?
Intubation also, ma'am, I'm not suspecting it to be difficult, as there was no perioperative complication in the last time the patient underwent the procedure.
But Himanshu, if we go to the literature, if we search the literature, we find that despite anticipating that these cases might not be having difficult intubation, despite that, we can have an incidence of failed intubation roughly 8%. It's as high as 7 to 8%, right? So always make sure that you have your difficult airway things there, even if you are not anticipating it's going to be difficult. Difficulty can arise in this patient. Okay.
Yes.
So you have done the history examination, you have seen your labs.
Yes,
now, in our institution, generally the PSC is done preoperatively quite early. But now this patient is posted for your surgery tomorrow as a first case, 8 a.m. So a day before you are going to visit the patient, what exactly are the pre-anesthetic advice which you are going to write down there or give to the parents of the patient?
Yes. I will first go through the PSC that has already been done. I will go through all the history and the investigations that have been done in the child. Then I myself will take the history and examine the child. Mainly, I will examine for presence of any upper respiratory tract infection, and I will also again examine the airway of the child. Along with this, I will also see the presence of superficial veins in the child for my IV cannulation. And if I am able to see the veins, I will mark the veins, and I will ask the parents or the nursing staff there to not remove that mark from the child's dorsum of hand. Then after seeing all of this, then if there is any investigation pending, I would like to order that investigation. If not, then I will give NPO instructions. I will write down the NPO instructions.
What NPO instructions you are going to give to this patient?
Mainly, my child is being fed by spoon feeding, by formula feed. So at least 6 hours, I will instruct them to give the last feed at least 6 hours before the surgery. And for clear liquids, they can give clear liquids up to 2 hours before the surgery.
So 6 hours make sit at 2 a.m. 2 a.m.
Yes, ma'am.
So no mother is going to wake the child at 2 a.m. to feed the child. So it's important you make them understand that you can give clear fluids 2 hours at 6 a.m. when they wake up, right? So it's very important to write the instructions for clear fluids as well as for the solid food, whatever they're giving, right?
Yes, ma'am.
So you said you're going to talk to the mother or the parents of the child. So what exactly are you going to tell them?
Mainly, I will counsel them regarding the type of anesthesia I am going to give to their child.
And very important, take a consent for any, because you yourself are saying that if this is a difficult airway case, difficult airway. So in the difficult airway case can go to any extent if things really turn out to be bad. So you should have your consents in place, right? So inform the parents about your protocol, but tell them that this can be a difficult airway. So isme problem ho sakti hai. So that you need to tell them prior. So now, next day, your case is at 8 a.m. as I told you. What time are you going to reach your OT?
I will reach my OT at around 7:15 a.m.
Okay.
My child is having stranger anxiety, so I need to pre-medicate my child. So for pre-medication to
what age the child starts developing stranger anxiety?
After 6 months of age, the child develops stranger anxiety.
I think 3 to 4 months there is mother separation, and then stranger anxiety comes at 3 to 4 months. So as nowadays what we have seen, yes. So so these are the kids who need to be pre-medicated. So are you going to go ahead with the pre-medication in this child?
Yes, ma'am. As the child is having only cleft palate defect. So I am not very much worried about the airway obstruction by my pre-medication that I am going to give to my child. So yes, I will pre-medicate my child.
Not very much worried. Okay. Your confidence can at times give you, but still you should be prepared. Yes. But because the child has undergone a previous surgery, which was uneventful, and no congenital anomalies as such are present in the child, so you go ahead with pre-medication. What pre-medication, what dose you are going to give?
I would like to give oral midazolam at a dose of 0.5 mg per kg. It comes out to be around, my patient is 11, weighs 11 kg, so it comes out to be roughly 5 mg. So 5 milligrams of oral midazolam I will administer to the patient.
How much time it does takes to act?
Around 30 minutes. It takes around 30 minutes.
So that's why you need to give it prior. What other options in pre-medication do you have to sedate these kind of kids, this age group?
Apart from the oral route, I can administer my medication by intranasal route. I can give intranasal midazolam or intranasal dexmedetomidine at a dose of 1 to 2 mics per kg to sedate the child.
1 to 2 mics, maybe 1 mic is generally sufficient. Himanshu, your case was relatively not a syndromic child, but suppose we had a slight suspicion of the child having Pierre Robin or something. Would you like to proceed with the pre-medication there also?
No, ma'am. In that case, because the airway is much more difficult in those cases because of relatively large size tongue and small jaw. So the risk of airway obstruction would be more in such cases. So instead of administering such pre-medication, I would like the mother of the child to accompany him into the operative room, or I can get an IV cannula already secured. So
it's
if I need
generally,
to administer.
what's the protocol there which you follow? If it's a difficult airway case, do you try to get a cannula and use and have an IV access prior to giving anesthesia?
Yes, ma'am. For anticipated difficult airway, we usually secure an IV line before taking the patient.
Using EMLA. Yeah, using EMLA, you can use that. Or you can just talk and have a good rapport with the child, give him a toy to play, give your mobile phone for him. You can use some non-pharmacological means also.
Yes, ma'am.
Or as a pre-medication.
Yes.
So suppose this child, when you went to give the pre-medication, the child was sleeping nicely in mother's lap.
Yes,
ma'am. So how are you going to take the child inside now? The child looks well asleep. In that case,
he might be well asleep in the lap of his mother, but the child will have strange anxiety. As soon as he sees us, he may start crying, and that crying may lead to increased secretions in his airway, which might lead to bronchospasm, laryngospasm, or any perioperative respiratory complication in my child, in my patient. So even in this case, if I am seeing a child to be very stable and lying in the lap of his mother, I would like to administer a pre-medication to such child as well.
Very rightly said. So now in patients with difficult airway, if you have an IV line, you can actually, and the child is still screaming or yelling, ideally you should avoid any sedative, but a small dose of IV ketamine that still protects the airway reflexes can be used in these cases. So yes. Now your child is nicely pre-medicated after half an hour, 45 minutes, and now it's time to bring the child inside. What preparations are you going to make inside the operation theater before you shift the patient inside?
In the operation theater, I would check my anesthesia workstation. I would ensure the availability of all the resuscitative equipments, self-inflating manual ventilation bag, suction catheter, auxiliary oxygen cylinder. I would ensure the availability of I would get ready my difficult airway cart with all the instruments that I need of appropriate size according to the size of my patient.
So just briefly tell me about what equipments are you talking of?
I'm talking about nasopharyngeal and oropharyngeal airways, LMA, video laryngoscope, bougie, flexible fiber optic bronchoscope.
Pediatric bronchoscope.
Pediatric bronchoscope.
So you're going to have these things available.
I will also keep OT temperature warm. I will also keep a preheated warm blanket.
Very nice. So that's very important that you have the IV line. So now you've brought your child inside and the suction machine also ready. Now you have brought your child inside, right?
Yes. Yes.
So how are you going to induce?
So I have already pre-medicated my patient. So once the patient is inside the OT, I would first ask my assistant to at least have one monitoring in the child to attach a pulse oximetry in the lower limb of the patient. Then I would start inhalational induction by using 100% oxygen with sevoflurane.
No nitrous?
No, ma'am, in our institute, we usually use 100% oxygen with sevoflurane. So I will begin inhalational induction by using oxygen and sevoflurane, and at every stage I will keep an eye on capnography. The child should be spontaneously breathing all the time. So while the child is while I am giving inhalation anesthesia to the child, I will ask my assistants to apply monitors in the patient. They will apply ECG, NIBP, and pulse oximetry has already been attached, and capnography I am already seeing on my monitor. So once the child is anesthetized, I will ask my assistant to secure an IV line. So after securing IV line, I will administer opioid fentanyl at a dose of 1 to 2 microgram per kg. Then I will proceed ahead.
Proceed ahead. Like what is that ahead? What are
So
you?
after now my child has been induced. So first I will do a check ventilation whether I am able to ventilate my patient by mask. So if I am able to ventilate my patient by mask, then I will ask my assistant to administer a dose of muscle relaxant. I will use atracurium in this case. The child is 11 kg, so I will ask him to administer 5 mg of atracurium. So after the child is completely paralyzed, then I will go ahead with intubation of
which blade with size you are going to use?
I will use a straight blade Miller laryngoscope, blade size number 2 for intubation as my first plan, as my planning. And I will use an RAE tube for RAE tube size 4 and cuffed for intubation.
Before I come to RAE tube, why did you select the Miller blade?
Miller blade is a straight blade. In pediatric patients, we usually prefer using a straight blade because first the tongue size of the patient is large, and also the larynx is situated higher up. And also the epiglottis is short, stubby, and the control over the epiglottis is difficult. So a straight blade will give us a better view of larynx compared to the curved blade.
This was relatively, you were not anticipating any congenital anomaly in this. Suppose the child had a peri-Robin, then again your plan would be the same, to use the same Miller blade or any different plan of anesthesia.
In that case, ma'am, my plan A would be to use a video laryngoscope. So if it is already a difficult area, then I would go with using a video laryngoscope.
But you will give your muscle relaxant.
If I am able to mask ventilate my patient, then only then I would go muscle relaxant. Otherwise, a child should be spontaneously breathing all the time.
Otherwise, you in deeper plane of anesthesia, you can just do a laryngoscopy. Kids can tolerate. So if it's actually a syndromic child, you without giving the relaxant also, you can go ahead doing a laryngoscopy with a video laryngoscope if you have,
yes,
and then secure the airway in a deeper plane of anesthesia. So that's also a very safe option you have. You said you will select a RAE tube. What do you mean by an RAE tube? What's that?
RAE tube is a ring Adair Elvin tube. So these tubes are generally designed for such cases. They already have a preformed bend. So that helps the tube to be fixed away from the site of surgery and gives a good field for the surgeon to operate.
It's all good for the surgeons. What good it does to you? Any good for you?
The surgeon gets a good view, so he won't displace the endotracheal tube much. So the chances of displacement or distortion of the tube would be less in these cases.
Right. So that's an advantage for you. Any disadvantage these tubes are going to have?
Disadvantage that first is that the curve is already preformed. So that may not fit at the exact position in all the patients. In some patients, it may come out of the lower lip. In some patients, it may go inside the oral cavity. So one problem is this. The other problem is that we can't pass a suction catheter through this tube.
Can pass, but it passes with difficulty. You can do, but it's
It would be difficult to
yeah,
pass.
it's generally difficult.
Yes.
Another advantage of this is non-kinkable tube also. That also comes under one of the advantages of RAE tubes, right? So,
Yes.
so looking at, you said that the tube does not it doesn't fit in all the patients because of the preformed curve. So now, if you are not getting that adequate size, nicely fitted RAE tube, any other options with the tubes you have?
I can use a wire reinforced tube, like a flexometallic tube.
Have a proper size RAE, you would go ahead with a wire reinforced tube. If this wire reinforced tube is also not there in your OTs.
So, if that is also not there, then I may need to cut my RAE tube to make it.
You can't cut your RAE.
completely.
Never cut an RAE tube. Never. You can use a simple micro cuff tube, but you will need to be very vigilant regarding the dislodgement, regarding the impingement of the tube with the retractors. So you need to be careful, but definitely you can use a micro cuffed tube also in these patients if you do not have an RE which is fitting in, or you do not have a flexometallic tube. Earlier, the people used to use Oxford tube, but that's more of an historical thing now.
Yes.
So, Komal, would you like to add anything on the airway now?
Yeah, so Himanshu, as you said, you can cut RA tube. No, you should never do that because it can create a very sharpened edge and that can actually traumatize the airway further. Okay. So you said about RA tube. Can you tell me few salient feature in the fixation of RA tube?
The RA tube should be fixed in the center. In the lower lip, below the lower lip, in the center of the mandible, by using a waterproof transparent adhesive tape.
Yeah, so you added two beautiful practical points, and if the preform bend or the knee of RA tube is too large for a particular child, so in that case you need to fix lower down on the mandible. Okay, so you can use a like roller gauze or some smaller gauze piece, and then you can fix it over. Now, okay, so till this case, you did first direct laryngoscopy, and your plan was to proceed under the direct laryngoscopy. So what if on direct laryngoscopy, you get a CL grade of 3 and you are not able to intubate the child's trachea? So what you are going to do next?
Himanshu was so confident that the child is not going to be difficult airway. Now you have landed him in some problem. Yes, Himanshu.
Now, my first step would be to take out the laryngoscope and then mask ventilate the child. Meanwhile, I am mask ventilating the child. I would ask my assistant to hand over a video laryngoscope to me. In our institute, we usually have a CMAC pediatric video laryngoscope. So blade size number 2 I would use. Then I would like to go ahead with use of video laryngoscope.
Okay, so that was your next plan. You beautifully said or pointed out one thing, that you won't like to miss any opportunity to provide the oxygenation whenever you get a difficult airway. So any other airway instrument like supraglottic airway, can this be used in such cases?
Yes, supraglottic airway can also be used in these cases.
So what is their role in such cases?
First, they can be used as an aid for oxygen, for providing ventilation. Second thing is they can be used as a rescue device in cases of cannot intubate or cannot ventilate. They can be used as a rescue device. And another way we can use them is that we can use them as a conduit for intubation. We can pass a bronchoscope and then guide our endotracheal tube through the LMA. And there have been a few reports of the surgery being completely done under LMA.
So, but I would still suggest you are working with us. Don't try to be that.
Because
we would prefer intubation only and try to restrict LMA for such cases just as rescue device, right?
Yes, ma'am.
Because the crux of the surgery is to provide a good surgical access, and we are little bit hesitant the use of supraglottic airway for the surgery. So if it's a difficult airway, then because of the multiple attempts, there can be some upper airway related issue. So any drug you would like to administer for such patients who have difficult airway and multiple attempts done for them?
Yes, ma'am. If multiple attempts have been done, and also this is surgery involving the airway. So because there is trauma to the airway tissue, that may lead to airway edema post-op period. To reduce airway edema, I would like to give dexamethasone at a dose of 0.1 to 0.2 mg per kg in such patients to reduce the airway edema.
So being a glucocorticoid, it can have anti-inflammatory effect and can be helpful. So while discussing the induction of anesthesia, you uttered word that you would use short-acting opioid fentanyl for analgesia, right? So can you elaborate what all things you can use for intraoperative analgesia in a child who is planned for elective cleft lip or palate repair surgery?
I would like to go with multimodal analgesia.
Okay.
First, at the time of induction, I have administered a rapid-acting opioid analgesic, fentanyl. Then, a cleft palate repair is a long-duration surgery. Then, I would supplement with a long-acting opioid. I will give morphine at a dose of 0.1 mg per kg. If during the surgery I get features that the child is having pain, like despite maintaining adequate depth of anesthesia, if I am seeing the child is having tachycardia after ruling out other causes, if the child is having pain, then intermittently I can give boluses of short-acting opioid like fentanyl, 0.5 microgram per kg. And at the end of surgery, around 30 minutes prior to the end of surgery, I would like to administer paracetamol at a dose of 15 mg per kg. Along with this, I can also give regional nerve blocks to such patients. Patients who is here for cleft palate repair, I can give nerve block, mainly greater palatine nerve block, lesser palatine and nasopalatine nerve block. And also new literature is also coming up for the use of suprazygomatic maxillary nerve block. So if possible, I can also give that nerve block to the patient.
Okay, so your multimodal analgesia will consist of opioid, non-opioid, as well as regional blocks.
Yes,
with the opioids, whenever you are administrating even for a rescue dose, you should have a good post-anesthesia care unit or for monitoring of the adverse event like respiratory depression and all that. So I hope at your institute you have such well-established PACO and you have protocol in place, right?
Yes.
Yeah. So okay, so you have started with the surgery. So for surgery, the surgeon is doing typical positioning, and there are a few surgical steps before the surgeon starts the actual case. So what all, being a shared airway, what all difficulties you can face during this phase of the surgery?
Yes. At the time of positioning, the child is usually placed in extreme head extension. So during the extension, the tube may come out. So there can be dislodgement of the tube. So I have to be careful about that thing. I will auscultate bilaterally and check confirm whether the tube is in right position. Then the surgeon uses a tongue retractor. While inserting that tongue retractor, there can be snaring of the tube. So I would be careful regarding the peak airway pressure. Then there is placement of a Dingman retractor to open up the mouth. So that Dingman retractor may cause external compression of my tube. So at that time also, I need to be careful regarding the peak airway pressures that are there.
And secondly, whenever they open the retractor, there can be even the endobronchial intubation. Okay, so you need to be very careful. For one thing, you said airway pressures. Any other technique which is more clinical can be used for the detection of such complications?
I can put the patient on bag ventilation, and then I can check for compliance of my bag. If the compliance that might give me an idea if the tube has been obstructed or not.
So you very well said that. So before starting the surgery, surgeon like to infiltrate the operative field with local anesthetic agent, especially the shorter acting like lignocaine and along with epinephrine. So what is your take on that? What all monitoring is required? What is its implication as an anesthesiologist for this case?
Yes, ma'am. As this area is highly vascular, the surgeon often use a local anesthetic with adrenaline so as to reduce the blood loss. With epinephrine, they usually use lignocaine 2%. So if excessive dose of lignocaine is given, that might lead to local anesthetic systemic toxicity.
So how
So
much you are gonna allow?
My patient's weight is 11 kg and the toxic dose of lignocaine with adrenaline is 7 mg per kg. So maximum I can allow 3 to 4 ml of lignocaine of 2% lignocaine to be administered.
Yeah. And anything else? Because you said you would like to proceed under multimodal analgesia and you will be giving some blocks as well. So you have to be very careful for local anesthesia, systemic toxicity. Okay,
Yes,
in
ma'am.
such cases. In addition, because of adrenaline, it can show some cardiovascular effect as well, right?
Yes, ma'am.
So
Yes, ma'am.
patient can develop tachycardia. So just for the sake of discussion, can you tell me if in a hypothetical case, this child is having persistent tachycardia, the heart rate is staying almost above 150, 160 beats per minute. So what can be your differential diagnosis for such persistent tachycardia intraoperatively?
For persistent tachycardia, one is there can be inadequate analgesia. Second, inadequate depth of anesthesia. Third, I might not have administered adequate amount of intravenous fluid. That might also lead to tachycardia, and then adrenaline infiltration. Then sometimes, if the child's bladder is full, and in some cases also tachycardia would be there, and if there is hypercarbia, that is also another cause for intraoperative tachycardia.
Okay, so you uttered about IV fluid. So which IV fluid you would like to prefer for intraoperative administration in this case?
I would prefer balanced salt solution, and I would use Holiday Cigar formula for calculation of my fluid.
Okay, so you very well summarized it.
So
Now I think Dr. Divya can proceed with the further discussion about.
yeah. So cleft palate, you said, was a relatively major surgery. So what do you anticipate any blood loss here?
Ma'am, if the size of defect is very large, if the size of defect is very large, then I think it would be a more complicated surgery, and
So
that
I'm
might
telling you
lead to
for this
hospital.
particular patient. Okay, if I ask about just this particular patient, are you going to have blood ready? You are going to have blood inside the OT or just cross-matched?
In my case, I would like to have a cross match with me. I won't like to have a blood with me in the OT. I would like to order for a cross match, and if there is requirement, then I can ask for release of blood from the blood bank.
Right. So finally, your surgery got done, and now it's the time to extubate the child. How are you going to plan your extubation?
And after the completion of surgery, first under direct vision, I would like to take out the throat pack that has been placed. Then I would like to suction out all the blood or all the clots that are already present inside the airway under direct vision. Once I have done that, I won't like to suction again in the airway because that might lead to damage to the sutures that have been placed. Then and I will extubate the child only once he has regained complete power and he is taking uh, uh, and he's taking adequate tidal volume at a regular rate. I won't extubate my child while he is deep. So I will extubate my child only when he regains adequate power and he takes in adequate tidal volume at a regular rate.
So important thing here to remember is you're saying that the child should be extubated calmly, smoothly. It should be a very smooth extubation, right? So now the child has been extubated, but because of some irritation, the child is always cranky once you even pull out the tube. How are you going to nurse the child here?
First, I would place the child in a recovery position or the lateral position. Then I will examine whether I'm able to hear a stridor, or if
Stridor?
I'm able to hear a stridor, that
you can see the drug if the child is having stridor or anything. So you have extubated. We are not anticipating any stridor right now in this your patient. You have extubated, but despite that, there can be secretion. So it's always better to nurse the child in a lateral position and shift the child in that position only outside the important thing which you need. Another thing which you need to consider while extubation is that the IV lines need to be secured very nicely. The child is going to be irritable. He can pull out your IV lines. So in this child, secure your IV lines, right?
Yes, ma'am.
What post-op complications do you anticipate in this patient?
My main post-op complication that I am worried about is post-operative airway obstruction. It has been seen that in cases of cleft lip and repair, post-operative airway obstruction, mainly due to airway edema, can take place even up to 48 hours after the surgery.
Okay, one is airway edema. What
Yes.
else? What else can you have?
Apart from airway edema, I can have other adverse airway events like laryngospasm or bronchospasm due to secretions or blood trickling down into the trachea.
Because your patient now had a laryngospasm. Laryngospasm can happen during extubation. How are you going to manage that?
If the patient is having laryngospasm, then first I would put a face mask on the patient. I will give a continuous positive airway pressure while giving a jaw thrust and Larson's maneuver to the child. If by giving only continuous positive airway pressure, if the laryngospasm breaks, then I will use this. If it doesn't break, then I may need to administer propofol to the patient to deepen the plane of anesthesia.
Can you give CPAP, slight CPAP also?
Yes.
At the pressures, right. So this was about laryngospasm you can have airway edema. Any other complications which you can, you said about stridor also.
Yes,
now, what are the reasons why your child can develop stridor?
One is airway obstruction is very common, so airway edema, and then airway edema may lead to stridor, or if there is trickling down of blood or any secretions, or if there is any hidden blood clot that may go down in the trachea. These all things may cause stridor. Also, there is air in the tongue. There is also edema in the tongue, and now the defect has been closed. So that also leads to less space for the tongue to be accommodated inside the oral cavity. That may lead to stridor.
So if now this is the problem, that the space is less, the tongue is not able to be accommodated inside, how are you going to manage this obstruction?
In this case, I would like to put a nasopharyngeal airway in my patient. Preferably, the child was operated on the left side, so I would put a nasopharyngeal airway on the right side.
Okay. Anything else which can be done to relieve this obstruction?
I'm placing the child in lateral position.
Can surgeon be helpful for you?
Leading questions for you to answer that.
My surgeons also place a tongue tie, or they stitch the tongue, which prevents the airway obstruction by edematous tongue.
And I think we've covered this. Anything you would like to add, Komal?
Yeah. So one more complication is the bleeding, right? So bleeding is the parents get anxious if they see the the child bleeding and all that. So there is one more this thing. As you secure the IV cannula, you need to sometimes restrain the child by providing the splinting or the boxer glove kind of dressing to his upper limb, so that because of the irritation of the suture lines, the child has tendency to rub the face or put hand in the mouth and all that. So this can also lead to the bleeding. So this is one more thing. So now, Himanshu, we have discussed almost everything. The throat pack you said can be retained throat pack, can be one of the reason for upper airway obstruction, right? So you have to be very careful. There should be a checklist in place that one needs to take whenever the throat pack has been put, and even after removal, the whole team should be informed. There should be a close communication between the surgeon and anesthesiologist. Okay, Himanshu, can you would like to tell me if because you are from a new generation who is more techno-savvy and all, so can you use ultrasound in these cases? What can be the the help from the ultrasound for conducting anesthesia in such cases?
Ma'am, we can use ultrasound for securing IV line if we are not able to see IV lines properly. Then we can use ultrasound to secure an IV line. We can do an airway ultrasound. By using ultrasound, we can measure the tongue thickness and other airway parameters by using ultrasound. And also for regional nerve blocks, we can use our ultrasound, as well as the child is having any respiratory tract infection. We can use a lung ultrasound to see if there is any consolidation.
Excellent, Himanshu. So I hope your information, the way you have given your answers, would be helpful for the others who are listening to you while preparing for their those who are preparing for your exam. Generally, this comes as a short case, but we have, I think, extensively discussed all the aspects of, tried to cover the pre-operative and the post-operative aspects of cleft palate. So even if it comes as a long case, it should be easy for you guys to handle this, right? So over to you, Ridhima.
Thank you.
Thank you, ma'am. I think first of all, I must congratulate you on Himanshu. Very well presented, very confident. I'm sure it's not easy to present in such a large platform in front of all the seniors. And definitely the credit goes to Divya ma'am, who's a wonderful teacher. And I have that personal experience. Sana is an amazing person, especially Komal. She's a dear friend, very hardworking, and wonderful to share a OT with her at my time. So I think Dr. Halil, can we take some question? Ma'am, there's few questions in the, I think you have well explained, there's no question, but still we can take few questions.
Yeah. I would like Himanshu to take them. If he's not able to answer, then of course,
definitely.
The ball comes to my court.
Dr. Halil, are you there? I think she's connecting. Meanwhile, I can ask you, there is a question. Are you using a cuffed endotracheal tube?
Yes, I mean, in these cases, we would use cuffed endotracheal tube because the risk of aspiration, because this is an airway surgery, we need a complete protection of our airway. We don't want any blood to trickle down the airway and cause aspiration. So yes, we will use a cuffed endotracheal tube.
We prefer using a cuff, but just in case if the adequate size, many a times it's not available also. In that case, we can go ahead with an uncuffed tube, but remember to nicely pack it's going to be packed. The surgeons are going to pack it nicely to prevent this bleeding. That you need to have that in mind.
Then there is one, please repeat how to fix CTT and circuit so as to prevent accidental extubation. That is one question in the chat box.
And that is very important aspect. I think I have seen myself experienced extubations during this, if the RA tube, especially with the RA tube. So now if this problem occurs more if the bend is lying outside, if it's not adequately fitted in your at the lip level. So if it's lying, then make a small roll and try to get the tube absolutely in the center, right? The tongue should not be lying on the either side, and then fix it on the mandible. I wish we could have taken a picture to show how the tube is fixed just in the midline at the lower chin level. Komal had described it nicely.
Yeah. So one more thing is, surgeon always do the painting and draping later on. Like once you fix the tube, later on. So use of self-adhesive plastic dressing is very much helpful. So if you paste that over and above your normal endotracheal tube fixation, so that is very much helpful. Secondly, regarding avoid the dragging of the circuit. Okay, because if the circuit weight is too much, then the accidental extubation is very much possible. So avoid the dragging of the circuit, fix the circuit nicely to the operating table, and so that the accidental extubation can be very well prevented. But then vigilance is the key. Always be vigilant, look into the surgical field, and there should be a close communication between surgeons and anesthesiologists.
Then Dr. Heli is talking to
the next question is why
can be a complication. It is in the chat box.
Himanshu has
definitely just a complication.
Yes, it is very much a complication. In fact, nowadays we find it's not just hypothermia, but many kids land up in hyperthermia also intraoperatively, because we are overcautious. At times, the child has been nicely draped also, and the warmer is also running. The lights are also there. So many times you will find that the temperature rises also. So a look at the temperature, intraoperative monitoring of the temperature is very important. It's hypothermia and hyperthermia. Either of the complications can happen in palate surgeries.
And tongue sutures.
That I think we talked at the end.
Tongue
Yeah,
suture.
we have covered.
I think most of the questions are answered. Just for the old Sikh examiner, I think when we were passing, there were very important rule of 10. I don't know now, so they don't ask, but just Himanshu, do you know rule of 10 in cleft palate?
He had described the Kellner's rule of.
Yes. As described, it seems.
Okay.
And Himanshu, do you know about steel induction? What is meant by steel induction?
Your child was sleeping nicely in mother's lap. You got him inside, and how do you?
That is not a steel induction. That is the steel induction. We are stealing the child from the mother's lap.
Yes. I was going to talk about that when I talked about that, but somehow it skipped my mind. Right. Thanks for pointing.
I think Madhuri ma'am wants to ask something, ma'am.
Yeah, Madhuri ma'am.
Yeah, with Dr. Divya's permission.
Yeah, of course, ma'am.
It is. You have covered almost all the points. But just for practice for Dr. Himanshu, have you elicited the history of obstructive sleep apnea in this child?
Yes, ma'am, I have taken.
And why is it important?
I've taken the history of snoring in these patients. Because musculature, there is also defect in the pharyngeal musculature while there is defect in the palate. So these children are more prone for developing OSA. Also, if there is micrognathia and a large size tongue, then they are more prone.
But how is this going to affect your management?
If there is a history of OSA, then there would be repeated episodes of hypoxia in these patients. Those hypoxia episodes may lead to increase in the pulmonary vascular resistance. They will change the pulmonary vasculature, which may further on lead to right-sided problem in the right side of the heart, may lead to cor pulmonale or right-sided heart failure. One concern is this. Another concern is during the time of extubation, there can be more chances of airway obstruction.
Yes, because you do a palatoplasty or a pharyngoplasty, so the chances of the obstructive sleep apnea may in fact increase post-operatively.
Yes.
Okay, and Himanshu, you said that you will pre-medicate with oral midazolam. So how is it available, oral midazolam?
And
what is the strength and all like?
Oral midazolam, we have ampules of oral midazolam which have 5 mg in 1 ml. Ampules are available. We usually here we mix it with honey, or we mix it with dextrose solution to administer.
So you use the injectable preparation only.
Syrup nowadays is
not available nowadays. Syrup is not available nowadays. Any other pre-medicants could be used in this case other than midazolam, and I think you told about dexmedetomidine. Any other pre-medicants?
Ketamine can also be used in these patients.
Yeah, but what is the problem of ketamine in these cases?
Ketamine can lead to increased secretions.
And not only secretions, we can manage with glycopyrrolate, but what they say is ketamine is the enemy of the plastic surgeon, because whenever you give ketamine, there is going to be a lot of bleeding from mucosal surfaces. So many surgeons do not like ketamine, but we are comfortable with giving ketamine by different routes. And there are other pre-medicants, like you can always tell these pre-medicants, I don't know whether you're using triclofos and Phenergan syrup.
Yeah, actually, we are not using them in
You are not using, but these are the various pre-medicants which can be used. Okay. Okay, and how about that? Suppose your laryngoscope blade gets stuck in that cleft. Have you taken any precautions for that?
Ma'am, I
didn't hear you saying any precaution. Suppose your blade gets stuck in that cleft palate, no, your baby has. Then what you will do?
I can use a roller gauze to cover the defect of the cleft palate, or
Roller gauze.
any, or
Hmm.
or I can use paraglossal method of passing the laryngoscope blade, or palatal
Yeah.
also there, and I can use
Yeah,
that.
I think you can use that. Dr. Divya, anything you want to tell about that packing that cleft? Like, should we routinely pack or only after the thing gets stuck should we adopt that measure?
Ma'am, actually nowadays this was a
We
left-sided.
don't do. Yes.
Yes. So it depends upon the kind of defect that is there. If it's a large
Okay.
defect, so that's my practice.
But
And
the blade used is the same. He told the Miller blade is used.
so if you use
So
them,
previously also Miller blade was only used and the cleft was there, but the blade gets stuck sometimes in the cleft.
left,
Okay. And one more thing is, what is the intraoperative surgical position that is given to the baby for cleft palate repair?
Mainly, the neck is kept in extension position. That is extreme extension of the neck.
Hyper extended neck position.
Yes.
Yeah. Okay, good presentation.
Thank
Shall
you.
I tell one thing here?
of course, sir.
Regarding the blade getting stuck in that palate, the more you experience it, the more you get aware of how to manage airway in such patients. That is the practice of cleft palate. I think at the time the Himanshu passes out the examinations, he will know how to get these things, get out of a trouble from these things. These are very common things. Whether you use Miller blade or you can say the curved blade, it's the same thing. Both of them can get struck. Roller gauze, the only thing is that you may not be having a uniform coverage of the cleft. Sometimes even with the roller gauge also you will have some that blade can still get stuck into it. The best is try to put the pressure on the ceilings rather than behind. Then that is the best part. And even if they put the ceiling, I think you will be able to see the glottis. That is not a problem with that. But it comes with the time. The learning curve has to be there. Just like Dr. Devya was just going to say in her practice, and she stopped there. So she must have gone to that extent to make it. I think that make the glottis visible with all the minimal efforts that come with time. So it's not an easy surgery. You ask me, palate surgery is not easy surgery. You are sharing the airway, your tube. Sometimes you have to hold the tube while sitting with the patient. No, on one side of the you are with the if you are using a JR circuit, so much of the inhalation you are inhaling, and by the time you reach home, so you are just like dizzy, like anything. You may not be able to sleep properly. Also, and you will be so tired. And then especially and all those issues will come out the our pregnant anesthesiologist going into the cleft palate surgery, then getting exposed to inhalation anesthetics, the nitrous and all those things. Well, everything has to be taken care of during these type of surgeries. The airway management I told particularly is always challenging. So it's not just the laryngoscopy. I think sharing the airway, holding the tube, the fixation, perioperative vigilance throughout the surgery, because when you're operating on the palate, surgeon, spare some surgeon also. They are also very stressed in repairing it, so they don't know sometime when the tube get dislodged. You have to be very careful with your bag and mask ventilation, or with the newer low flow circuits. You have to be vigilant at everything. Sometimes the saturation, may not be coming up because of the neonates. It's a problem with whether you put on the ear or on the fingers or toe fingers. Sometimes the saturation is not showing up there. The ECG, sometimes they get electric disconnections. So you have to be vigilant with all monitoring gadgets that you should not miss, because they don't give you much time. They desaturate very rapidly. The thing sometimes, even if you miss for 1 and 2 minutes, the monitor, I think you should be very much cautious to put the monitor on or put the stethole. The precordial stethole is very important for that. Just made to stick to the old regimes also, and it will be safety for the patients. We just can't depend upon the modern electronic gadgets. They may be just have very friendly, but rightly Dr. Madhuri said it's very, very important. You have to be very well aware of all the monitoring methods. The best monitor is your eyes, your ear, your fingers, and your brain. Those should be awake. That is more important in these type of cases.
Absolutely. A vigilant anesthetist, you cannot replace, especially complications can happen anytime. True. Anything?
Any suggestions?
Type of tube, RA, there are two types of RA tube, South Pole and North Pole. Which type you use, Himanshu?
Himanshu.
We will use a South Pole RA because we will be doing intubation.
But Himanshu, here another catch here. Dr. Heli may not be knowing about this thing. It also depends upon the surgeon. Some surgeons prefer the positions, below the head. Some prefer position above the head. So it also depends upon the position of the surgeon. Where are they comfortable? It also depends upon the cleft palate's exact location, type of defect, the complete, incomplete. Surgeon stands on the left side of the patient, right side of the patient, behind the head. So I think the South Pole, North Pole, you sometimes decide accordingly. That is my experience, what I've seen, because wherever the surgeon stands, you have to be opposite around. And whether it's if the patient stands on the head end, then South Pole is the best. If the surgeon stands on the, the right or left side, because assistant will be standing along with in front of the surgeon. So you have to be putting on the head end. Then North Pole may be better option. So I think that also has to be counted. We should spare Himanshu for that.
All the questions are addressed. Can we conclude, sir?
नहीं पास किया कि नहीं किया बोला ये तो बताओ इतने बड़े लोग
Pass, Madhuri ma'am, बताओ.
two internals
Madhuri ma'am
and
will
so
tell.
many externals. He has to face so many
Himanshu.
externals and 2 internals.
Himanshu is freed. Himanshu is freed. You're free, Himanshu. Poor boy. Okay, thank you.
The burden he was carrying since past 1 week when we told him that he's going to present, no?
It's
How
a
many
mock
people
drill,
are going to
mock
ask?
drill,
Good presentation.
mock
Yeah,
drill for
good
the
presentation.
finals actually. That's
Yeah,
good.
but I am like really happy the way he had presented and the way he's prepared also. He studied very
Yeah.
extensively.
Divya, this is something like internal and external examiner. Everybody he has faced. So he can face any exam now.
Absolutely, absolutely.
I was more stressed than Himanshu today.
That's a good one coming.
See, no, Dr. Heli has become an examiner in just one go. Isn't it, Heli? Before you started this program today and now, I think you are sitting in a very comfortable position to take any examination of any candidate, isn't it?
Thank you, sir.
Yeah. I think it's great. The time is there, 8:05. I think we should be finishing here.
Yeah.
Any suggestion
Thank you.
from anybody?
Thank you so much for giving me the opportunity to be in this platform, sir.
No,
Thank you so
opportunity
much,
को अपने ऊपर opportunity आती है, ऊपर से आती है, भगवान से आती है. हम तो सिर्फ उसको coordinate कर रहे हैं.
नहीं sir, coordination.
लॉटरी पड़ती है ऊपर से जिसके नाम आ जाते हैं उसकी आती है.
Coordination के लिए thank you.
Coordination के लिए हो.
भगवान से coordinate कराने के लिए.
नहीं वो तो फिर रामदेव या किसी और के पास जाना पड़ेगा, मेरे पास. I think it's a good session. I was missing a little bit because another mock elections were going on for the Maharashtra state and our governing council. So I was little busy in that. But I tried to listen to Himanshu what he said today. I think he's prepared well and he will be doing fine in the examination. Himanshu, don't worry, you will be passing. The way I think Dr. Divya will also be there to help you out because you have already given one good examination today. I hope you get this case also in the final, so it will be easy for you.
That's going to be a lottery for him.
Try to give him this case only.
That would be a
Dr.
major.
Komal is already agreed. She has already agreed. She will give this case only.
हिमांशु तुम थैंक करना सर को भी अगर तुमको यही केस मिले तो.
ये तो इस केस के लिए तो सबको मिठाई खिलाएगा.
चलो.
So,
Thank you all. It was like
Thank
fun.
you so much. Thank you.
Enjoyed this session. Thank you.
so we
Okay.
should end up
Bye.
today's class.
Night, bye.
First of all, thank you everyone. And we should end the class by saying long live ISA.
Long live.
Long